Reporting and responding. At 0100 hours, we were called to a 69-year-old female, conscious, breathing, PV bleed, on warfarin, code 2A. On arrival, the partner greeted us. He stated that the patient was having a shower in her ensuite. As we walked through the bedroom, we saw that there was a blood clot on the bed and a towel drenched in blood. As we politely entered the bathroom, the patient was found sitting in the shower, extremely pale and cyanosed, still bleeding into the drain. Observing the ensuite, there were pools of blood around the toilet bowl, blood clots, and a second towel drenched in blood. Her eyes were spontaneous, motor function was normal, however, she was dazed and confused, GCS 14. We did a rapid history and vital sign survey and quickly moved her onto the stretcher and into the car where IV access was gained. Relating. I was originally patient care as my mentors thought it would be an excellent way to practice awkward situations. However, given the severity of the case and the state of the patient, my mentors took over and I was then setting the stretcher up and reassuring the partner who was extremely worried. If I were patient care officer, giving the IV would have been my only limitation. Given the nature of this case, a blood pressure was the first and most important vital sign to acquire. The patient was extremely hypotensive with a blood pressure of 70 on 40. We then put her onto the stretcher, put a towel between her legs against the bleed and raised her legs. From there, a neurological assessment and a head-to-toe was performed in case the patient had fallen and hit her head. I personally have not experienced this before. In these conditions, I can imagine how awkward it could be for a female patient in her position with two male officers. I now have the knowledge to treat a patient with the same injury. However, talking to the patient and building the trust between us would be my biggest challenge. Reasoning. The most important issue with this case was the amount of blood the patient had lost, the warfarin, and her confused state. According to Medline Plus, warfarin is used to prevent blood clots from forming or growing larger in your blood and blood vessels. It also states that it can cause life-threatening bleeding. After doing a neurological assessment and a head-to-toe, there were no bumps, lumps, bruises, abrasions, or lacerations, which would indicate no fall or other bleeding areas. It was obvious that the patient was dazed and confused due to the significant blood loss. The simplest technique, laying the patient in a supine position and raising her legs, was used to control her bleed and blood pressure. After 5 minutes of her raised legs, her face started to become a pinkish warm color and her lips were less cyanosed with a blood pressure of 90 on 50. If the bleeding wasn't controlled, the patient could have gone into hypovolemic shock or even death. Her cyanosed and pale state was obviously caused by the blood loss but also her upright positions on the toilet and in the shower. Rest and reassurance was extremely important in this case, not only for the patient but for the partner as he was in a worried state. Asking him to grab a couple of towels and to pack a bag for his partner was a good way to provide scene control. Reconstruction. There was nothing I would have done differently. I did, however, make a mistake with access and egress. I placed the stretcher on the concrete driveway next to the door. I didn't notice that there was a 2-inch drop at the edge of the driveway. I lowered the bed to the right height for the patient and put the brakes on. The patient was quite large and in a dazed state, which caused her to slump onto the stretcher, which moved 2 wheels off the edge. Luckily, the stretcher didn't tip over. This made it difficult to lift the patient as the stretcher was now on an angle. I have now learned to be aware of my surroundings and to make sure the stretcher is in a safe and stable position for the patient and paramedic officers. The passive leg raise, according to the American Heart Association, Circulation and First Aid Science, has no real evidence to support that it can be used as a treatment, but rather used as a diagnosis.